Hey everyone, we're going to pick back up with urinary system, and we're going to start off on page 106 in your course pack. And we're going to talk through three main activities of the nephron. Okay, so those three main activities or jobs of the nephron are filtration, tubular reabsorption, and tubular secretion. So before we get into the nuts and bolts of how all this works, let me take you back to some concepts that you may have learned in an earlier chapter. That's in the blood vessel chapter. Back in the earlier chapter, we talked about capillaries. So let me draw out a capillary for just a moment. All right, so we know that blood is flowing in this direction through the capillary. We know there's two battling pressures, a hydrostatic pressure that we call blood hydrostatic pressure. We also know this is the same thing as blood pressure, and that's around 35 millimeters mercury at this arterial end. We know that that blood pressure or hydrostatic pressure tends to drop by the time you reach the venual end. We know there's another pressure that battles against that when it's called blood osmotic pressure, and that one is based on the salts and proteins in the bloodstream, and it's about 26 millimeters mercury. It tends to stay stable along the length of your capillary. Okay, there are some pressures out here. There's interstitial fluid hydrostatic pressure, and there's osmotic pressure as well for the interstitial space, but we're not going to worry too much about those right now. These are cells in the interstitial space. We're going to mainly concentrate on what's happening in the capillary. So we know that filtration is a process that occurs due to a higher hydrostatic pressure at the arterial end of your capillary. So we know that to push fluids out of a capillary, we have to have high hydrostatic pressure. Which pressure is going to be the one responsible for returning fluids in at the venual end and allows for reabsorption to occur? That's going to be the salt and protein pressure. That's osmotic pressure, and the only way it can accomplish this is that it overcomes the blood hydrostatic pressure. You see now that 26 is higher than 15 to 17. So we've kind of covered these two terms, filtration and reabsorption, in the past. Now we're going to look at these two terms in the context of being in the kidneys. All right, so on page 106, now we can start with the information there for the glomerulus. The process of filtration occurs here because you have high hydrostatic pressure. And the way you accomplish this and the way you prevent reabsorption from occurring is you not only feed this capillary bed here with an arteriole, you also drain it with an arteriole. So that maintains a high hydrostatic pressure so that we only filter and we do not allow reabsorption in the glomerulus. All right, so filtration should occur in the glomerular capillaries. We know that's also known as the glomerulus. Filtrate should include blood plasma, dissolved substances like nutrients like glucose, for instance, but we shouldn't be finding larger items such as red blood cells, white blood cells, platelets, or blood proteins. So to make this point, let me show you this image. This is a colander or a strainer. If you cook spaghetti or if you rinse off lettuce leaves, this may be what you use. If you're putting in blood, you've got large cells like red blood cells. You have cells like white blood cells, and you've got molecules of water that are traveling down. So these holes here have to be a certain size to allow water to pass through and some of the dissolved items, but not so big that we allow larger molecules like proteins or even blood cells through. So imagine that these were your glomerular capillaries. Your capillaries allow certain items to be squeezed through and captured by that Bowman's capsule. So imagine that your Bowman's capsule sits around here like this. We're going to squeeze or filter through smaller items, and those smaller items are what we call filtrate. So that could be things like water, that could include glucose, that may also include waste products or toxins, that may also include things that you no longer want in the bloodstream, some ions like ammonia, for instance. But notice what we're not going to filter through are the large things like blood cells and proteins. They should not be captured in that filtrate. We'll add toxins down here, of course, too. Okay, so in order to be in the filtrate, these items must be small enough to pass through the glomerular capillaries. Now, if you have an inflammation in the glomerulus, those holes may become enlarged, and then you get blood cells passing through, or even proteins. We know that's a warning sign for something going on in the kidney. All right, so that's that Bowman's or glomerular capsule. So these items that are captured as filtrate, where do they travel next? They travel into this first portion of the renal tubule. What's it called? That is our proximal convoluted tubule. All right, so on your worksheet, page 106, let's talk about how filtrate forms. We know that the afferent arteriole is going to feed into this set of capillaries, so let's label that one there as the afferent arteriole. And this set of capillaries here, of course, is the glomerulus. And this exiting vessel is called what? That's our efferent or efferent arteriole. Now, in order to maintain pressure in the glomerulus, we must have high hydrostatic pressure or high BHP. So if we don't have high enough pressure, there's a specialized set of cells that sit right in here. And those specialized cells are called our JGA. What do those specialized cells monitor? They're monitoring blood pressure. And if blood pressure is too low, you can't form filtrate. So what do these cells now release? They now release renin. Notice it's spelled with one N and not two. This renin now travels to the liver. And of course, in the liver, angiotensin 1 is now released, converted to angiotensin 2. Angiotensin 2 comes back to squeeze that efferent arteriole, and that helps to keep the blood in the glomerulus unable to escape. That's how we continue producing filtrate, even if we have low blood pressure. Ultimately, angiotensin 2 leads to the production of aldosterone. Of course, that comes from which gland? That comes from the adrenals, and ADH is going to come from the posterior pituitary when that blood pressure is too low. All right, so let's talk about this for just a moment. Once again, we have afferent arterioles feeding in, efferent arterioles leaving. Here are those JGA cells that are lining those areas of those vessels, and then we're going to monitor the blood pressure using these sets of cells here. Okay, we don't talk so much about the macula densa in this course, but we do talk more about these JGA cells. But they are also involved in maintaining blood sodium concentration and blood pressure. All right, so just a reminder that filtrate contains items that are small enough to pass through the glomerular capillaries. Anything that's too large, like a blood cell, should not be allowed to pass through and be filtered out. Anything that you filter through these glomerular capillaries is captured by the Bowman's capsule, and it travels on down this PCT. So in order to reabsorb those items, we must have a mechanism for pulling them back in. If you end up with red blood cells or proteins in this PCT, there is no mechanism in place to reabsorb them. What that means is if you filter out blood cells or blood proteins, they will end up in your urine. So anything filtered here must be small enough to not only pass through this filtration membrane in the glomerulus, but we also have to have a mechanism in place to reabsorb those items as we travel through that renal tubule system. About midway down page 106, let's now point our attention to net filtration pressure, or NFP, for just a moment. All right, so let's talk about pressures once again in these capillaries. We have a BHP, technically it's called a glomerular BHP, of around 55. So that is a push of 55 millimeters mercury. And what we mean by that is we're pushing out of the glomerular capillaries with 55 millimeters of force. The blood inside those glomerular capillaries, we know that's called BOP, are pulling back in with about 30 millimeters worth of pull. So they're attracting fluids back into that set of capillaries. Normally, this would be our only conversation, just hydrostatic pressure battling osmotic pressure. But this time we also have yet a third pressure. It's called capsular hydrostatic pressure, and that's the force of the fluids that just got filtered out. They're out here in this capsule, and they're pushing to get back in the capillaries. So that capsular hydrostatic pressure is around 15, and it's pushing back into the capillaries. So notice that you've got a force of 55 millimeters mercury pushing out. You have 30 for osmotic pressure pulling in, and 15 out here in this capsular space pushing in. So if I do the math, I'm going to say this is a force out, okay? So let's put a positive sign there. These are forces in, so let's put negative signs there. Do the math. 55 minus 30 is 25. 25 minus 15 leaves us with an overall push of 10 millimeters mercury of pressure. So our ability to force fluids out is ultimately 10 millimeters mercury of pressure. That number is one you'll want to know. The normal NFP, or net filtration pressure in the kidney, is 10 millimeters mercury. Okay, so that's one number to note there on page 106. Likewise, let's talk about the glomerular filtration rate. Your kidneys can only filter at a certain pace, and that is about 120 milliliters per minute. So when we're filtering blood, even if you've had a lot of fluids to drink and you now have more fluids to filter, your kidneys only work at one speed, and that's their glomerular filtration rate. We do tend to lose our GFR over our lifetime. Brand new kidneys and children are going to have the best filtration rates. When you reach adulthood, you lose about 10 millimeters off per minute per decade of life. So we do tend to see by the time people are in their 50s through 80s, we see a decrease in that GFR, but that's normal and that comes with age. What is not normal, however, are these numbers here. If you're below 60 milliliters per minute that you're filtering, you're into an area called kidney disease, and below 15 milliliters per minute, you're into what's called kidney failure. The problem with kidney disease and kidney failure is that the kidneys are unable to process the toxins. Toxins may build up in the bloodstream, and only dilute urine may be released. So in other words, we're not able to properly remove the toxins and waste products out of the bloodstream because those kidneys tend to fail. All right, so on this page here, 106, you'll also want to know the GFR. That is the normal glomerular filtration rate of 120 milliliters per minute. Just interesting here to look at that normal kidney function is GFR of 90 or higher, so see 120 is a really fantastic number. Stage 2 kidney disease is, of course, a little lower there. Stage 3 gets you down into not working very well, and then we know that below 15 is critical for kidney failure. So near the bottom of page 106, let's talk about renal clearance for just a moment. This particular measure is done so that we know how effective your kidneys are at removing items from the bloodstream. These items typically are not reabsorbed back into the bloodstream, so that doesn't complicate and confuse us by knowing that they're removed and then reabsorbed. The measure here is given in a minute's time, but in laboratory settings, we may say use 30 minutes or an hour to be able to measure the renal clearance. Two products that are often used in renal clearance are inulin and creatinine. Inulin is a polysaccharide that can be injected into the bloodstream, and we can watch and measure how much of it is excreted and removed from the blood over a period of time. Creatinine can be done in any lab setting. It is something you naturally produce as a byproduct of muscle metabolism. So we can, of course, watch that one be removed. High levels indicate that the kidneys are not effectively removing or clearing this item from the bloodstream. Okay, so let's take a look at page 107. On page 107, we have tubular reabsorption at the very top there in the PCT. So let's track where we've been so far. We've come in through the afferent arteriole, and items that are filtered here are removed by the glomerulus and captured by the Bowman's or glomerular capsule. From that capsule, these items now travel into the proximal convoluted tubule. your body will decide to take some of these items from the proximal convoluted tubule back into the bloodstream. So the substances in the convoluted tubule are called the filtrate, and we're choosing to move these items back into the bloodstream. Okay, so here in the peritubular capillary is where we return those items to the blood. Those items travel through a venule to the interlobular or cortical radiate vein. From the cortical radiate vein, they travel through the arcuate vein, and then of course on back to interlobar and renal vein. So this process of reabsorption occurs now because we have a lower hydrostatic pressure in these peritubular capillaries, and we have mechanisms in place to reabsorb the items that we're going to cover now on page 107. You'll want to put a star beside the once absorbed pathway there on page 107. That is where we're going to use portions of that pathway to fill in some tracings that we had on a previous page. So here's the list of items that we're going to reabsorb back into your bloodstream by way of the PCT. So let's take a look at page 107 for just a moment. That chart there in the center of the page is where we want to look. Okay, so if we're in the PCT, these items are items that we need or want back in the bloodstream. We're going to take about 60 to 70% of the sodium from the PCT, that is the filtrate, and move that back into the bloodstream, which is in the peritubular capillaries. Okay, these are items that we want to keep. We want most of our glucose as well. Let me explain what it means to be a 180 transport maximum. That means if you have a certain amount of blood sugar in your urine, you can pull a good bit of that back into your bloodstream. So for instance, if you have in your filtrate 110 milligrams per 100 milliliter plasma of glucose, you can take all of that because it's within 180. If your blood glucose, or your filtrate glucose rather, is 150, you can take all of that. However, if your filtrate glucose is 210 milligrams per 100 milliliters, then you can only take 180. You only have 180 channels for our glucose to travel back. It is coupled with sodium, but you can't take more than 180 units, which is 180 milligrams of glucose per 100 milliliters of plasma. Anything above 180 is dumped into the urine, and so you lose the sugar into the urine. This is exactly how diabetes mellitus works. If blood sugar is higher than 180, anything in excess of 180 is dumped into the urine. Okay, so that would of course increase the amount of fluid lost because glucose is an osmotic diuretic. We know that water follows salt, but we now also know that water follows sugar. So any water present in your PCT will stay with that excess blood sugar, which is now filtrate, and escape into the urine. So that's what we think of as an osmotic diuretic. Water will follow the sugar, it escapes. You not only now have polydipsia, but you've got polyphagia because you've lost those sugars needed for ATP production. All right, chlorines, bicarbs, these two help us to regulate our blood pH levels. We'll talk more about those in a minute. Water is absorbed here, and we call it obligatory water reabsorption because we're going to take it back whether or not we need it. And then amino acids are also reabsorbed here as well. All right, so let's keep track of what we've done so far. Here in the glomerulus is the process of filtration. Okay, that's the process of removing blood plasma, ions, nutrients, waste products from the blood, and we capture it by this capsule. We travel first into this area here called the PCT. We know there are a set of capillaries that wrap around this entire nephron. Those capillaries are called our peritubular capillaries. Now, in order to reabsorb items in the PCT, we have to move them from that tubule system back into those peritubular capillaries. So some items that will experience reabsorption in the PCT that we just got through talking about are sodium, glucose, what else? Chlorine, bicarbonate, some water, and amino acids. All right, so how much glucose can you take back into the bloodstream from your filtrate? Up to 180 units, nothing more. The excess gets dumped in the urine. And the water reabsorption that occurs here is called obligatory, meaning you're going to take back that water whether or not you need it. Okay, so that's where we are so far. Bottom of page 107, let's now turn our attention and talk about nephron loop reabsorption. It is a fancy specialized process here called countercurrent multiplication. All right, so when water travels into that hairpin curve that we call the loop of Henle or the nephron loop, we know that fluids and plasma flowing down through here is called filtrate. So the filtrate that's traveling through this descending limb of the loop of Henle, we only pull water back out and move it into the peritubular capillaries on the descending limb. On the ascending limb, we reabsorb sodium and chlorine back into the bloodstream. So you say, well, why do we do it separately? Doesn't water follow salt? And of course, the answer is normally, but not here. In this particular location of the tubule system, we only have water reabsorption occurring on the downfall and sodium and chlorine reabsorption going up the ascending limb. So we do this in order to maintain salt concentration of the filtrate. So that's why we separate the two. Water falls on the downside, of course, sodium and chlorine on the ascending side. I keep this straight because remember that water falls down a waterfall, and of course that's where we reabsorb water is on the descending limb of this loop of Henle. So the whole point here of this special process called countercurrent multiplication is to adjust the saltiness of the filtrate traveling through this nephron loop. Okay, remember that term, countercurrent multiplication. It occurs here in this nephron loop. So let's keep track of what we've done so far. So far we've covered filtration. We know that occurs in the glomerulus. We've traveled with the filtrate into this PCT, and we've reabsorbed a number of items from sodium to glucose, water, amino acids, chlorine, and bicarbonate. And as that filtrate travels down toward this nephron loop, we have reabsorbed water on the descending limb, and we've reabsorbed sodium and chlorine on the ascending limb. So the whole point of this countercurrent multiplication was to adjust the saltiness or salinity of the water and the sodium in that filtrate. Now this filtrate has reached another set of twisted curves called the DCT. So let's now turn on over to the next page, that's 108, and talk about tubular reabsorption there. Once you reach the DCT, the type of reabsorption that occurs here is typically driven by hormones. So let's follow the picture and the pathway that we've had so far. Blood is flowing in through the afferent arteriole. It travels here into the glomerulus. That's where filtration occurs. We remove items in the bloodstream such as water, solutes, waste products, nutrients, good and bad. Now we travel into this PCT, and perhaps these items were not reabsorbed in the PCT, so they travel on over here to this nephron loop, down, back up, and now we're over here into this DCT. Okay, so that's how far we've made it in this renal tubule. Items can still be reabsorbed here in the distal convoluted tubule. They do make their way back into this set of peritubular capillaries, and of course if they're reabsorbed, they travel to a venule, then to the interlobular or cortical radiate vein, and then back to that arcuate vein. So let's erase that. Okay, go back to that arcuate vein, and then on out through the interlobar vein and renal vein. So things that are reabsorbed here must follow part of the pathway through the renal tubule and then hop back into this blood pathway to exit the kidney. That is on page 108. You may want to make a star beside that one. That will help us with a pathway we saw a few pages earlier. I'll go back and hit that for you in a bit. So notice the items that we reabsorb here are going to be facilitated by hormones. If aldosterone is present, then you will have sodium, and of course water follows through ADH reabsorption. This time we call this combination facultative reabsorption because we have to assist the reabsorption using hormones. Likewise, if PTH is present, then we have calcium reabsorption occur here. No PTH, no calcium reabsorption occurs. So let's focus now on the DCT area. Okay, we know this region over here is known as the DCT. And the type of absorption that occurs here is going to be limited to hormonal-driven reabsorption. Okay, so let's review how aldosterone works. There are specialized cells that sit here that are called the JGA cells. What do they detect? They monitor and they detect low blood pressure. And when the pressure is low, they release what chemical? They release renin. Renin targets the liver, and of course the liver releases angiotensin 1. Angiotensin 1 is then converted into angiotensin 2. And angiotensin 2 comes back here and squeezes that efferent arteriole. What does that do for the blood pressure in the glomerulus? That will increase pressure inside the glomerulus. So that way we can still maintain filtration that occurs there. Okay, angiotensin 2 also targets the adrenal gland and promotes the release of aldosterone. So aldosterone comes over here to this DCT, and aldosterone will tell that DCT to insert sodium channels. So that's going to increase sodium reabsorption. So from there, sodium moves from the DCT back into peritubular capillaries to a venule to the interlobular vein. You know the story, back to the renal vein from there. So we know if aldosterone is present here, then we increase sodium reabsorption, but we also get rid of potassium. So we dump potassium into the filtrate, and if you're dumping it, it's going into the urine. Okay, so we know that's a sodium-potassium pump that helps to drive that process. Caffeine will inhibit aldosterone's effects on the DCT, so it will naturally cause you to lose more sodium and more urine if you happen to have caffeine in your system. Water also is going to be reabsorbed. It's kind of a 1-2 punch when you have low blood pressure. We release aldosterone and ADH. ADH, of course, increases water reabsorption here. So this is called facultative reabsorption. That is in contrast with obligatory. This means you only reabsorb water in the DCT if ADH is present. If there is no ADH present here, what happens to the water in your DCT? That water would continue on to the collecting duct and end up in the urine. So you'll notice on your worksheet that caffeine, glucose, and alcohol can all impair the process of reabsorption here in the DCT. They work differently. Alcohol inhibits ADH release from the pituitary, whereas glucose acts as an osmotic diuretic. What does that mean to be an osmotic diuretic? That means we're pulling fluids out into this DCT and losing it in the urine. Caffeine also can act as a diuretic. All right, and then finally we just covered PTH and calcium there. It helps to increase blood calcium levels if needed. Final page is going to be 109 for this particular discussion. All right, so we've talked about that already. Let's talk now about secretion, page 109. So if you have items that were never filtered, let's go back to the beginning of this story. Items that were traveling through the afferent arteriole travel next through the glomerulus. If they are not filtered, where do they go next? They go to the efferent arteriole, not to the renal tubule system. So if there's no filtration, those items travel to the efferent arteriole. They travel then to these sets of peritubular capillaries that surround this whole tubule system. And oftentimes here in the DCT, especially in the DCT, we see items being dumped from the bloodstream into the filtrate. So this means we are doing the opposite of reabsorption. We are taking items from the blood and dumping them. Well, that filtrate is destined to become urine. So this is the way your body gets rid of items that it does not need, such as potassium, if aldosterone is present. Hydrogens may be dumped if you have acidosis. Urea, uric acid, and creatinine are all waste products of some form of metabolism. Urea is a waste product of protein metabolism, while uric acid is a waste product of RNA metabolism. We know that creatinine is a waste product of muscle metabolism, and this one is used for renal clearance calculations because it can be filtered and secreted, but it's typically not reabsorbed. So we don't see the levels in the bloodstream tending to increase. So I'll make a note here. This one is great for renal clearance calculations. All right, so let's review secretion, because secretion is opposite to reabsorption. This time we move items from the peritubular capillaries to the urine. We're ultimately intending for this stuff to be dumped. So we've got things like potassium, hydrogens, and then wastes: urea, uric acid, and creatinine. Okay, I just want to focus for a moment here on hydrogen ions, talking about that for just a moment. If you happen to be dumping hydrogens, those peritubular capillaries that wrap around the DCT contain that hydrogen. Those hydrogens are moved under the response of aldosterone from the blood into the DCT. So when you're dumping these items through secretion, your body intends to get rid of these items in the urine. The reason you might dump hydrogens is for a very specific reason, and that has to do with blood pH. So if the blood pH is too acidic, all right, that means that you have metabolic acidosis. You will increase hydrogen ion secretion, and that of course is here in the DCT. That's right there. You will also increase bicarbonate reabsorption. Think back, we just talked about where we reabsorb bicarbs. That was in the PCT. Okay, so how does this help you? If your blood is too acidic, you're dumping acid and you're reabsorbing base. So hydrogens are acids, bicarbonates are basic. Let's flip it the other way. If blood pH is too alkaline, we call that condition metabolic alkalosis. That could be due to vomiting, for instance. That could also come from eating too many Toms or antacids. So in that situation, you want to make your bloodstream more acidic. So this time you're going to decrease hydrogen ion secretion in the DCT. You likewise will decrease bicarbonate reabsorption. Don't want more base if you're already too basic, right? In the PCT. So let me give you a helpful hint. Let's use this bottom right-hand corner for helpful hints. If your blood pH is too low, then your compensation here, the way your kidneys fix your blood pH problem, is to increase secretion of hydrogens and reabsorption of bicarbs. If your blood pH is too high, meaning too alkaline, the compensation is to decrease hydrogen ion secretion and bicarbonate reabsorption. Let me also emphasize this. You only secrete hydrogens, you don't reabsorb them. Likewise, you only reabsorb bicarbonates, you don't secrete them. So you're not having to figure out which word we're talking about. You either increase or decrease hydrogen ion secretion, and likewise, you either increase or decrease bicarbonate ion reabsorption. You may need to view this slide a couple times. Jot these notes down so that you can review them. This will help you with acid-base balance coming from laboratory. All right, so that takes you to page 109, and I will pick back up with a separate video for the remaining portion of this chapter.